I am pleased to introduce today's speakers, Jennifer O'Keefe and Alissa Fadem. Jennifer and Alissa have both worked at Bellefaire JCB, which is the parent organization of Monarch Center for Autism, for 10 years within the residential setting. They started out as direct care staff for children with mental health diagnoses. During this time, they pursued master's degrees in counseling and eventually transitioned into the world of autism. Alissa and Jennifer can currently direct 2 of our boarding academies under Monarch Center for Autism. Most clients within their specific programs carry a dual diagnosis. It is with these experiences that they have developed an awareness and ability to diagnose and treat children and adolescents with comorbid disorders. So without further ado, I will hand it over to Jennifer and Alissa.
All right, thank you. Good morning, everyone.
Good morning.
Okay, we're going to get started. All right, so we're going to go to the second slide. All right, so this is just kind of an introduction to what we're going to be covering during the webinar today, specifically the prevalence of ASD and mental health conditions. It is well known that there's a growing trend of those being diagnosed with both autism and a mental health condition. And so our goals for the webinar today are first to address awareness. We want to bring your attention to the common disorders being diagnosed secondary to autism. Secondly, assessment. We want to help you know how to look for a secondary diagnosis and the prevailing symptoms. Third, actual diagnosis. Our aim is to guide you through knowing what you're looking for and when it goes beyond autism. And then lastly, treatment. Talk through how to get the help you need and how to provide effective treatment strategies. Okay.
Awareness and symptoms of autism. What we already know. 1 in 60 children are being diagnosed with autism. Autism is often described diagnostically as social impairment, communication impairment, and repetitive or stereotyped behaviors. Y doesn't always follow X. All people have routines, specifically a morning routine. I'm going to ask you all to think about that right now. What time is your alarm set for? How many times do you hit snooze? How long does it take you to get ready? What time do you need to leave for work? Now think about this. Your alarm didn't go off for some reason, and you woke up late, and now you have to rush. You understand why your routine has to change, why you might have to rush. We can adapt. A child with autism might not understand why and can't just adapt. This will cause an increase in anxiety and possibly behaviors. We might assume that they should be able to adapt. Should is a dangerous word. This is why it is so important to create predictability for those who can't. Can you imagine going through life never fully understanding why everyone is always rushing you? Children with autism need to live in a world in which Y always follows X. However, that's not always possible. Treatment providers, parents, and teachers are responsible for doing their best to create the environment that is predictable, consistent, and structured. But we also need to prepare and teach the child what to do and how to react if and when things change, because they will.
Okay. Slide. Okay. So we're just going to kind of run through the common co-occurring conditions. According to recent studies and Alissa and I's experience, the most commonly diagnosed co-occurring to autism at this time are mood disorder, anxiety disorder, and obsessive compulsive disorder. If you look in the circles below, just some of the common symptoms in mood, what we typically see is mood swings or mood instability. There's oftentimes irritability, which can be alone or followed by aggression. We typically see irregular sleep patterns, changes in the appetite, We see hypersensitivity, which can look like being overstimulated in different environments. There's typically periods of time where there are elevated moods followed by maybe depressive moods, but we do tend to see a fluctuation between the two. And then we also see oppositional behavior that can fall under this category. So again, it doesn't mean that all of these are always present, but these are just some general examples. In anxiety, we typically see issues with concentration. We tend to see isolation. So in our programs, that might look like somebody hibernating in their room more often or being less engaged in activities that were once enjoyable to them. So loss of enjoyable activities, fatigue, sleep, sadness, and worry. In obsessive compulsive disorder, we see repetitive behaviors, ritualistic behaviors, obsessive thoughts, compulsions, a need for control, inflexibility, and an inability to manage change. What's important to know is that there is a lot of carryover between all three of these diagnoses, and so you may see a little bit of both as symptomology in somebody that you're looking to assess. So that's something to keep in mind. Just a little note is that it can often be difficult to detect one specific mood disorder based on the presentation of the individual, despite knowing that you clearly see the symptoms. And so this is typically when we diagnose with a mood disorder NOS, not otherwise specified, meaning that maybe they don't fit the specific criteria for a bipolar disorder or a depressive disorder, but the symptoms are so prevalent that it warrants something on the diagnostic criteria. Okay, this slide is covering a little bit of the assessment portion. So what I want to first cover is talking through the why something might start looking different, why behaviors may start to appear. And so, there's a lot of why out there, but there's a few areas that we have observed in our experience that kind of target when the changes might occur, and when we hear from families or people involved with individuals that something looks or feels different than it used to. So when these things are happening, it's not necessarily the cause, but we see it as something that can exacerbate the symptoms that maybe were previously there, or it could be symptoms that are new. I would say most often we see a typical onset of some of the secondary symptoms to autism around the age of puberty. And so for the individuals that we treat, that could really start as young as 11 or 12, all the way up through till 16 or 17. And so we're seeing body changes, hormone changes, and that is a really common period of time of when we might see a referral, or when we're starting to hear from families that there became aggression or there became mood swings. And I think it looks different than a neurotypical teenager because it's gone to a different extreme. So again, typical onset would be around the age of when they're hitting puberty, which again can be very individualized, some developing later than others. There's also a period of transition that seems to affect them. And so we've observed this to happen when maybe a family's moved to a new home or a new state. Typically when kids enter a residential treatment facility or a boarding program of some sort, or they're starting a new school, we've often seen that their behaviors start to tweak. Life cycle changes are another important thing to keep in mind. So when somebody moves away, a sister goes to college, there may be some behaviors that they have absolutely no ability to communicate, and so you start to see it come out in different ways. And then also looking at family dynamics. Was there a death in the family? Was there a divorce? And again, all of these things could be kind of brewing for a while, but it might be that this life change or this transition really kind of exacerbated it and took it to another level. Okay, the next is the mental health symptomology, which kind of falls into the category of the what is happening, what are we seeing. And again, it's very similar to what we looked at on the first page. But just to note, we're really taking everything into consideration. And so, we're looking at what is their history? What do the clinical reports say? What was going on in their developmental milestones? What does their language development look like? And then was there any, past trauma that we would want to take into consideration? Breaking down the different symptoms that we talked about and kind of where they fit into the different diagnostic categories, whether it's, a mood disorder, OCD, anxiety, or, it could be something else. And then just wanted to talk through, some of the common phrases that we hear from families. So when we're looking at somebody that's presenting with some of these mood symptoms, we often hear parents say, my son changed or my daughter changed, something happened. And I think a lot of times we forget to take into consideration the puberty and the onset of these hormones that maybe tweaked the behavior for them. But we're looking then when they're saying these things, did they stop sleeping? Did their appetite change? Are you seeing periods throughout the day where they're really happy and elated, and then maybe 2 days later you can't get them to come out of their room? And really looking at it as how it fits into both the autism and then how you might also observe it as a separate issue. When we're looking at OCD, common phrases that we often hear are, little by little, he started to take more control, and we didn't realize what was happening. He can't even leave the house now. And so there does seem, when you're able to kind of take a step back and look at everything that was happening, whether it was a week prior to the behavior, a year prior to the behavior, paying attention to the things that changed in their life and your life and how that really could be affecting them and how there was a progression potentially of the behaviors. Okay, what are the barriers to treating these symptoms? I think first and foremost, when you're dealing with autism, the biggest barrier that you're going to run into is, do they have functional communication? And so we work with a really wide range of the spectrum. We are serving kids that have no language, kids that have limited language, and then kids that have full verbal language. But it doesn't always mean that if you have language, you're going to be able to tell us exactly what it is that's going on for you. So we're always paying attention to what level of communication do they have, what can they tell us about how they're feeling and what's going on with them. And if they can't, then we need to rely heavily on reports, observations, information from parents, staff, and really making sure that we're gathering all the necessary documentation that we would need to make sure that we are making the correct diagnoses. We're also looking at cognitive ability. So maybe they do have full verbal language, but are they accurate in being able to report what is going on for them? And if they can't, then how do we build in supports to get that information and also teach them for the future? And then also looking at self-awareness. Do they have it? What are they lacking in that area? So having an understanding of what's going on for them, both, in the world, in their brains, in their bodies. And so, I think it makes it much more difficult when they don't have communication. And when they do, we should consider ourselves lucky. But I would say that that's probably the biggest barrier that we run into in terms of treating the symptoms.
Absolutely. The next thing that we're going to talk about is dual diagnosis. Okay. As Jenny talked about in a previous slide, she listed out a lot of common symptoms in mood disorders, obsessive compulsive disorder, and anxiety disorders. A lot of those symptoms we also see in a child who has autism. So we say sometimes they walk the line. The question is, when do you separate them out? When is it part of their autism, and when is it a completely separate diagnosis that needs to be addressed simultaneously? So as a clinician, we tend to use the concept when daily functioning is impaired. However, many times you are already describing a child who's on the spectrum as having an impairment in their daily functioning. So again, how do we know? First, we need to look at the symptoms and or the diagnostic criteria, as well as the apparent antecedent or triggers to the identified symptoms or behaviors. For example, if you have a child that becomes upset or angry, or even moody when told no to something, that might not meet the diagnostic criteria for a mood disorder. However, if you observe the child and describe them as being irritable, on edge, moody, unpredictable, and those descriptors cannot be better explained by a symptom of their autism, such as functional communication deficits, or change in routine or a transition, then you might be looking at a mood disorder and the need for further assessment. In terms of anxiety, you would look at it in a very similar way. Anxiety is often a symptom of autism, even though it's not an exact diagnostic criteria. We look at pulling it out as a primary or secondary diagnosis when it impacts the child in a more global way. For instance, a routine has changed, and a child might respond as if they were literally being punched in the stomach. That's autism. However, if they are walking through life thinking that at any moment, at any time, they will get punched in the stomach, never knowing what to expect, and change patterns of behavior because of it, that might be a diagnosable anxiety disorder. So again, it's about looking at the whole child. So the question that we ask is, do you have to choose between treating symptoms of both diagnoses? No, you don't. It's just like for years, alcohol and drugs and mental health have been co-occurring. This we've sort of been calling the new co-occurring. You used to treat them simultaneously. Does it matter which one is causing the most impairment in daily functioning? Truthfully, it's likely a combination. You have to treat the whole child because the diagnoses will likely impact each other. And how much does the exact diagnosis really matter? A lot of people spend a lot of time arguing a diagnosis over a different diagnosis. But what we'd like for you to take away from today is that the symptoms are what matter. They matter more than the name that is given to them. As clinicians, we have to treat the symptoms. We'll talk more about treatment in upcoming slides.
Okay, we're going to talk for a few minutes through common misconceptions. So the first one is they can talk so they understand. False. It's really important to remember that you can't assume that because a child with autism has verbal language, that always means that they can very clearly tell you exactly what's going on for them. And so again, this becomes part of the work that we do as clinicians, as therapists, but assuring that when you're treating a child with autism that might have a co-occurring diagnosis, that you are taking both aspects of it into consideration. We have found that often many children with autism's receptive language is much better than their expressive language, but there should be some ruling out of exactly what it is that you're gathering in terms of information. It's also important to be aware of to help them be aware of how they feel and what they feel. Let's see, the next common misconception is that they don't have autism. So, you know, in the work that Alissa and I have done, there have been many times where we've been asked to assess a young child, adult for autism and be able to look at everything that's going on, look at the whole child and be able to figure out what could be autism and what would be diagnosed separately. So you need to know what you're looking for and what might present differently in somebody that, you know, had a different history or had different developmental milestones or has more risk-taking behaviors than typically what we see. So it's important to remember that there is a range. When you're looking at the diagnostic criteria for autism, starting with deficits in social communication and interactions, you know, on one end of the range, you may be looking at somebody that has limited language, that is using an augmentative communication device to communicate and is at the basic steps of that development. Whereas, you know, in our experience, we've met people who are at a much different level where they have the full verbal language and they have the ability to communicate and can hold reciprocal conversations with you. But when you start to bring into the conversation slang phrases or sarcasm or different issues related to body language, you immediately notice the confusion that comes across their face and that there's a misunderstanding of what it is that you're trying to convey to them. We also look at deficits in nonverbal communication. So, you know, for some of the children that we serve, it's very difficult for them to make eye contact, and that may be a goal that we're working on with them. There's limited understanding of body language, and so we're constantly trying to promote those types of goals. For somebody else in the range, you could be looking at facial expressions and trying to teach them how your facial expression could lead you to the way that somebody might be feeling. And then looking at deficits in developing relationships and social contexts. So a lot of our youth that are younger chronologically and developmentally have a harder time discriminating with people when they want to get their need met versus when they are looking to build a relationship with somebody. We also look at a range of, these older adolescents who maybe their social deficits in developing relationships come in terms of trying to figure out how to have a girlfriend, making small talk, or looking to get an emotional need met. So again, we're always paying attention to each range of the spectrum. The next misconception that we typically observe is he should be able to control himself. So we typically look at all behaviors as having a function, no matter how they present themselves. And so it can be challenging to be able to differentiate when you are seeing this large variety of how the behaviors present themselves, that they are coming from the same place. So whether it is a child with autism or another diagnosis, it's important to take into consideration that they may not always be in control, and that children do typically do as well as they are able to. The next one is that he used to be able to do that. Another piece of advice that we typically find that we're sharing with people is that when you have a mood disorder or you have really severe anxiety or OCD, there are going to be plenty of periods of time in your life where those symptoms are going to be exacerbated. And when they are, you may lose your ability to function in the same capacity that you could have the day before. And so it's really important to remember that sometimes just with, when you're presented just with autism, but also when you're presented with a co-occurring diagnosis, that there are things that get in the way and that it's our job to help them regain those skills. But it is okay sometimes to take a step back, knowing that today they might not be able to accomplish what they did yesterday because something has fluctuated with their symptoms. And then lastly, his behaviors are coming from a different place. So it's not necessarily easy to sift through and diagnose when somebody's behaviors that look so vastly different could be coming from the same place, but they do manifest differently. And the best way that we can think about describing it is when you're looking at somebody that has more of like a diagnosis of what we kind of describe as like classic autism versus somebody that maybe is being treated right now for autism and a mood disorder, but they've had completely different histories. They've had different paths. They've been in different settings, and they've grown up in different environments. And so we're going to talk through a few examples of kind of breaking down what we commonly see and then giving examples of what we might typically see when we're working with somebody that we consider to have risk-taking behaviors. So the two kind of target functions of behavior that we're going to talk through, the first one is denied access, and the second one is attention. So when we're looking at denied access, what we commonly see is somebody that we might observe yelling, whining, flailing on the ground, banging their head, trying to get the item anyway, and maybe there's some self-injury and aggression attached to the behavior. We typically hear phrases from them of, give it to me or I'm going to bite you. So that's more of like our typical behavior. When we're looking at what the behaviors could present themselves as for denied access when we are dealing with somebody that's a little bit more savvy or somebody that has higher risk-taking behaviors, we're going to be looking for verbal threats to harm themselves or others, gestures to potentially harm themselves, and what we like to call hostage-holding statements. And so in this scenario, we might hear a phrase of, if you don't give it to me, I'm going to run away. If you don't give it to me, I'm going to go hurt myself. And again, when we get into some of the treatment modalities, we're going to focus a little bit more on how we address the different behaviors and responses that we observe in these kind of two different areas. But it's important to think about how the behavior can still be the same, but you're hearing and seeing a different presentation. And then secondly, when we're looking at maybe somebody that is seeking out attention, more commonly we would see yelling, maybe mimicking of others' behavior, somebody that's typically looking to outshine the other person, get that staff member or person's attention by grabbing them, pulling them in, anything that it can do to kind of steal the show. When we're looking on the extreme side or somebody that has more of the risk-taking behaviors, it may look like, you know, quiet, isolation, loneliness that turns to sadness, leading to thoughts of death or depression, which could potentially result in self-harm. And so again, we always take these behaviors very seriously, but as we get into some of the treatment modalities, we'll also talk about exactly how we address them. Okay.
So finding treatment providers is a really important part of this process. Part of the assessment is going to be a mental health assessment conducted by a mental health professional. That person must understand autism, and they must understand how to treat the whole individual. I think that is one of the most difficult things that we find in the field is someone who's able to merge both of these populations together and have an understanding of both. The other thing is that it's really important to have a multidisciplinary team that includes the therapist or the counselor, a psychiatrist, a behaviorist, and then obviously the teacher. It'll also be really important to conduct a functional behavior assessment along with the mental health assessment to find out what the functions of these behaviors are, because that will lead to different kinds of treatment and treatment modalities that we'll be using in talking about in the future. So one of the treatment modalities that we use is dialectical behavioral therapy, also known as DBT. And DBT is designed to help people change patterns of behavior that are not effective. Typically, it's used with clients who struggle with self-harm, suicidal thinking, or even substance abuse. Key concepts of this technique are geared toward mindful awareness, which is a higher level skill. We aren't seeing a lot of our children who are on the spectrum be able to get this level of mindful awareness, and so a lot of these techniques are essentially too high for them. But with modification, clients that have a lower cognitive functioning or are more concrete, these techniques can be very useful. Concepts that can be taken and modified are the fact that you're trying to not inadvertently reinforce negative behavior. And by doing this, a key concept that we utilize here a lot is either over-responding to a behavior or under-responding to a behavior. And whether or not you over-respond or under-respond will really depend on the client's motivation and the function of that expression or the behavior.
Okay. The other treatment modality that we find that we use most often is cognitive behavior therapy. And so I would say that for many people in our profession, especially with this population, we probably use this much more than we realize. So cognitive behavioral therapy is used primarily to help those with autism to, A, regulate their emotions, B, develop impulse control, and C, improve their behavior. Again, taking one step at a time. This is not always such an easy thing to be able to do. So CBT has also been effective in reducing feelings of anxiety and depression, which again are two of the diagnoses that we see co-occurring most often. And it helps the individual to see and visualize changes in thoughts and perceptions of various situations. And again, we're going to continue slides moving in the direction of giving you guys actual visuals that we have found successful in tweaking DBT and CBT for this specific population. Again, over the next few pages, we're going to show you an incorporation of visual supports, which becomes highly necessary for the individuals that we're serving. So when you're working with anybody that has a diagnosis of autism, it's imperative that you're building in visual supports throughout their day, and that can be for a variety of reasons. It can help with organization of their day. It can also help with organization of a therapy session or, what you're trying to accomplish with the individual. And then it's also helping them to kind of anticipate and predictability of what's coming in throughout their day, but it also can help with prediction of behaviors and teaching them through the visual supports. So we'll get into a little bit more of that. And then also we wanted to just talk briefly about the benefits of an eclectic approach. The model that we follow here, as well as what we've learned in our experience, is that taking one modality isn't necessarily as beneficial as kind of incorporating a little bit of each. So we are looking at principles of applied behavior analysis, dialectical behavior therapy, cognitive behavioral therapy, and then everything that we know that works really well for the autism population. Okay, so on this slide, we're breaking down a little bit more of what could be useful in terms of implementing cognitive behavioral therapy with somebody that has the co-occurring diagnoses. So like I had mentioned, it's important to look at ways of using visual supports. One of the things that I feel like we know when a child first comes into our program or when first beginning to work with anybody on the autism spectrum is they, like Alissa mentioned earlier, they need structure, they need predictability, and they need to know what's coming next. And so on the top left, you'll see what could be considered a very simplified first, next, then board. This is something that we use daily. This could be used in any aspect of treatment. But what I think is important is to think about not necessarily overthinking what resources are already available to you when you're looking at the co-occurring diagnosis. And so taking a concept as simple as first, next, then and translating it into how we teach kids about behaviors, how we teach kids about changing their behaviors and thinking about their behaviors. And so you can see that I put it like kind of equaling a page that would be a little bit more in-depth, maybe for somebody that is a little bit more cognitively developed in solving a problem that they had. And so it could be daily with some of the youth that we serve, that we are building in sheets like this when they have behavior, when they have a problem, so that they can see what was going on for me ahead of time, what happened, and then what did I do about it. And then we're constantly looking at creating other options. What else could you have done? But again, the visual support really goes a long way for them. Then at the bottom, you would also see you know, we have done a lot of work using bell-shaped curves to help kids look at ways of targeting their behavior. So the bell-shaped curve kind of helps our kids look at, again, what was happening, what was maybe going on inside of my body, how did I feel, what did that look like, when it got to the point of being heightened. And so a lot of times we use phrases like, what was the buildup, when did the explosion happen, and then how did you recover? And then what we try to do, this again can be used for things like anxiety or depression. And so if you were feeling anxious, what caused the anxious feelings? What were you able to do with thought stopping? If you weren't, where did it go to? And then again, what could you do differently next time? And then we're always trying to translate these visuals and some of these skills that we're teaching them into real life scenarios. And so sometimes that could literally be mock, doing mock trials or doing role plays with somebody about how they're going to handle it next time. What we find the most successful is that it's far more important to practice what to do next time or how you could handle yourself better when they are not in the midst of one of these behaviors or in the midst of one of these struggles. And so we practice it when things are going well or when they're in a good place so that they're more likely to have a better conceptualization of what it is that they should be doing next time.
It's also really noteworthy to talk to your clients about and to understand yourself that just because they understood it one time or in session or in this one scenario, that they're going to be able to translate that to a different scenario. We often teach children how to take a break, and that taking a break is really necessary, that we've done these, first I feel upset, next I take a break, then things will be, and I'll be able to calm. And we realize that if we teach the break only in one environment, that when they may be in the community at maybe a museum, they can't utilize that skill because it's not transferable. They can't translate what they have been taught very concretely in an abstract way. And so we have to try to teach concrete tools in each kind of real life scenario.
So Alissa brings up a good point. I always like to use an example. A couple of years ago, we had a young man with us who all of the work was around coping skills and what we were teaching him and what he could do in these moments when he was really distressed or somebody was agitating him. And so he had identified that going to our sensory room or going to a quiet, contained space away from other individuals was was what was most effective to him. And, you know, we thought this was great and this was really effective because we had this place for him, both in his residential environment as well as the school environment. But shame on us, he went into the community and he had an altercation with one of his peers, and it didn't end as well as we were able to coach him through in his residential and school environment. And, you know, after the behavior, we sat down with him and we reviewed what happened, what was going on with you, how did you feel, what transpired. And then we said, what could you do differently next time? And he said, well, I could go to the sensory room. And shame on us, there's no sensory room in the community. And so it's important to always really be honing in on, like, what is something, like Alissa said, that can be adapted across all environments, all scenarios, and maybe giving them a couple different options in case one of them doesn't pan out.
And the other good thing that we are able to do in our setting, because it is a live-in residential setting, and I realize that that's not necessarily translatable to everyone that's listening today, but we can practice in all of these settings. We can practice these techniques. We kind of call it life on life terms. If they're struggling at dinner in the common area when they're eating dinner with all the peers, that's when we're trying to target these behaviors. That's when we're trying to teach these techniques. And we're setting up those scenarios maybe outside of the moment to do the teaching opportunities. So it's not that we are teaching in one specific setting. We are teaching across all settings.
Okay, so there's, this is just really a resource page. There's a really great website, and again, we have a resource section that at the end of all of it that you can kind of see where we got some of this information from. But again, looking at some of the CBT models and what might be helpful to the youth that we're serving, you know, here's some different worksheets, kind of helping them make the connection of starting with how I feel, what I did, what else I could have done. And then again, maybe keeping track of something like a thought log. And then again, the visual, first I had a thought, then I had a behavior, but there was a situation that precipitated all of this, and there may have been an emotional attachment to the thoughts or beliefs. Okay.
I'd like to talk a little bit about subjective units of distress scales. I'll refer to them as subscales from here on out. We utilize these a lot. What they are able to do is they're a concrete representation of an abstract concept. So it puts a number and a description to a feeling, which then correlates and corresponds to a certain kind of coping technique. So a lot of times our kids don't understand maybe what the feeling means. They can identify a feeling, they can see a picture and understand that that facial expression means bad. But then if I feel sad, what does it feel like for me? And feeling is a very abstract concept. And so we want to try to make it very concrete. Maybe when you feel sad, this is what your face looks like, but this might be what happens to you. And then teaching them what can you do when you are sad to bring yourself back to maybe being happy or back to being content. So that's what we are trying to do. And we're also trying to transfer all of these to all different environments. And so when we're teaching this, we're trying to teach it first in moments of calm, not in moments of distress, because as people, we all learn better when we are not stressed out. And it's important to have them start to identify what happy feels like, what calm feels like, what they're doing when they're feeling happy and calm. Concretely. On the next slide, I'm just going to go back and forth between the two. We've created a subscale with a specific client. It's very important that it's client-driven. So they determine the numbers. They determine what the name is, if they're able to. And then self-identifying coping skills. A lot of times, our kids can't tell you what the coping skills. They don't really understand what will make them feel better. So it's a lot of trial and error. And so again, it's about asking and seeing, oh, you're singing, you're playing video games, you're doing your art. What number are you at? To connect that feeling, what I'm doing right now, is number one. And then, you're starting to yell and you're starting to swear. That's what this feels like when you're a number two. And so then what hopefully through a lot of practice, they are going to then be able to identify, I'm 3 right now, and this is what I can do to become a 1 or to become a 2.
Just a bit piggyback, I think two important things to think about also with the subscale is that you have to get everybody on board. And so it has to be across all environments, but everybody that's working with the youth needs to have a really good understanding of what this means. So whether it's mom checking in after you come home from school or your residential staff checking in with you throughout the day, it's imperative that everybody have an understanding of what it means, how you should coach them through it, and the maintenance and keeping up with it so that it doesn't just become a fallen resource. The other important thing is that a lot of times the youth that we work with that are on the autism spectrum, do really well talking about things or saying that they understand feelings or that you can show them a picture, but it's really important to also then, once they've been able to look at a picture, be able to look at images of themselves, whether it's through video modeling or whether it's through just an image of them representing how they think they feel when they're angry, so that you can always reference for them, like, this is what it looks like, or using a mirror and having them practice these different scenarios. Okay, so I'm going to talk a little bit about safety thinking zones. Something that we didn't get a lot into, and again, this can really relate to a lot of the diagnoses that we've talked about, but we, over the past couple of years, have seen a few clients that have come in with mood disorders, but specifically maybe something along the lines of like schizoaffective disorder, or those that have really intrusive thoughts that could potentially lead to concerning behaviors, or that are very difficult in helping them get through their day-to-day. And so there was a young man that we worked with who had both the autism diagnosis and schizoaffective, which is where a lot of this information is coming from. But what we've learned is that it's really important to kind of separate out the symptoms. And so when you're thinking about just thoughts and the way that thoughts can be presented and the way that they can be perceived by other individuals, it's really important to help that young person have that same awareness and understanding. And so what we did was we created safety thinking zones. So rather than ever associating any type of like level system or any feelings of punishment, we really want to focus on how you know when you're in what zone, what does that mean internally, what does that mean externally, and how can you independently or others help you kind of manage through it. So for instance, if you are somebody that is having really intrusive thoughts about hurting somebody else and you're not really sure what you're going to do about those, it's important to have a reference for how you can manage those different emotions. So, when you're looking at maybe perhaps somebody in the green zone, you always want to also help them identify when you are kind of doing everything right, when everything feels good, and where you're going to label that for yourself. So, you're earning the things you like, you're having fun, you feel good, you feel safe with your body, your thoughts, and your words. At this point, you probably, along with what Alissa was saying about the slides, you're going to identify, like, do I need to do anything different? And at this point, you probably don't need to. Then you might want to consider representing some type of warning zone, like when maybe I'm having a thought that I should tell somebody so that I can assure that maybe something doesn't come of it. And so one of the big emphasis that we've placed on this type of thinking zone is that we want you to tell us how you're feeling. We want to know. We'd rather you didn't hide these things and then have an acting out behavior that could be dangerous. So we're always rewarding or, encouraging the communication. So again, this level, what we've identified is that you are feeling unsafe or you're thinking about something. You might be thinking about hurting somebody. You might be thinking about hurting yourself, but it's important that you're communicating it. And then how can staff support you and how can you support yourself? So you're not in trouble, but maybe we need to have a higher level of supervision, or that, this is a good time to be talking to somebody about it rather than just letting it stew. And then lastly, we're kind of looking at like the red zone, which would be the high risk zone. And this might be like you have acted on your thoughts, you have acted on your behaviors, you need some more support, you need somebody to monitor you. But again, it's that safety aspect of what the interventions are that are being put in place based on safe thinking.
This can be related back to the concept earlier that we talked about where Y doesn't always follow X. What we're trying to do with individuals is really help them understand that Y is happening, and we're making it concrete, and this is what you do when this is happening. And it's almost like you're teaching them a script of behaviors. This is what you do when this happens. And we can repeat it over and over and over again because they don't have predictability. They can't say, well, Y doesn't always follow X, or they need a predictable environment. And so if I'm thinking and feeling this way, this is what's going to happen. This is how people are going to respond, and this is what's going to then happen, and this is what people are going to expect of me in this environment versus the other environment.
And then the other thing I think to keep into consideration is just that constant reassurance to them of like, if you haven't acted on your behaviors, like you're not in trouble. You haven't crossed that line, but also like sitting them down and being able to identify like what won't help. We focus so much on like coping skills and what you could do to make things better or what will help, but there should also be an emphasis on what won't help. So if you're in that agitated state, is it better for you to take a break and tell staff, I need a few minutes, don't talk to me? Is there certain music that you might listen to that's going to exacerbate those symptoms? But thinking about what will help and what won't help. And then on the left side of the page is, so this is what we used to kind of deem a writing prompt. So it's important that if somebody has writing skills that they can typically, or that they can write things down and that there can be an appropriate time and place for processing. So in some cases that you would do it with the staff because in that moment you need help solving a problem. In other cases we might say, this is a really great topic for you to talk about with your therapist, and then they would have a journal and they would save it and take it with them. But what you can see is that it kind of brings it back to the subscale that Alissa referenced, which is, again, identifying the number, then how you feel, so identify, targeting the number in connection with the feeling, why you feel that way, and then what it is that you can do to help solve the problem in that moment.
So social thinking, for us, I think that some of the key concepts for this are to always connect the concrete with the abstract. Understanding societal norms, unwritten rules, they're all very abstract. And so if we can connect negative behaviors to concrete outcomes, then you're going to possibly be able to teach the skill or teach the concept in a better way. And it's easier, potentially easier for them to understand. We use the 5 is Against the Law curriculum a lot. It's a point scale, which is very similar to what we've been talking about within the subscale, is that you're identifying a number, level, a value to a behavior. And you're either saying that it is not against the law at all, or it is terribly against the law. Because as professionals, sometimes when you're dealing with mental health population only, you talk about probation officers or that'll land you in jail. And our kids don't get that. They might be exhibiting some similar behaviors that might, especially if they skirt the line, and that could end up with some criminal charges. However, they don't understand what that means. They've never lived it. They can't understand the not concreteness of it, the abstractness of what is jail. I know that it's a bad place, but what does that mean? And so by making something concrete and giving it a point value in a scale is really helpful. Another thing that we talk a lot about is expected versus unexpected behaviors. And the really value of these concepts is that you're not giving judgment. Because who are we to judge what you're doing? We can just identify concretely that this behavior is expected on the playground, but it's unexpected at the library. Instead of saying that's inappropriate or that's weird, because again, you're putting judgment value on a specific concrete behavior. And it translates from situation to situation. Again, we're teaching these concepts to these kids in a variety of settings. We're teaching them what's expected at school, what's expected in a public bathroom, what's expected in a library versus what's unexpected at the grocery store, or what's expected at home versus what's expected at your job.
Okay, so like we had alluded to, a lot of the resources that we've talked about today can be found on this page. And then we will kind of talk through some questions and answers. So I wanted to, there was a few things that came up that we wanted to just kind of run through that have been questions. And then if there are things that maybe are a little bit more specific, we could probably find a way to connect following if we don't get to everybody's questions today. But I know a few of you have asked about the slides. And yes, there will be an option to get copies of all of the slides. This will be posted. The recording will be posted as well as the slides and the whole PowerPoint. That'll become access to everybody. And then again, if there was something in the slides that we used that isn't on the resource page, again, you should be able to access it through the slides, or you can contact us following the webinar. I noticed that there was a few questions about assessments that we use, and what we do here, which I guess is probably the easiest to talk about, is because we are an autism-specific program, we typically start with a lot of observation, and we do a lot of data collection, but we are conducting an assessment of basic language and learning skills and an assessment of functional living skills. And we also, because Alissa and I are, again, working with this co-occurring diagnosis, we're really honing in then on the mental health assessment. So that is something that helps us go through their developmental, social development, family history. Again, we're looking at a lot of areas of like, were there past mental health diagnoses in the family, and reviewing clinical documents as well as talking to anybody that's worked with the individual that kind of helps us gather the information. I think in our experience, we have seen a lot of scenarios where there have been prior mental health diagnoses in a family that kind of can help us think a little bit about what might be going on for the individual that we're serving at the time. And then I know one person had kind of just asked a little bit about like when you should reassess. And I would say we typically do a reevaluation every 6 months to a year. And so if you're not necessarily seeing progress or you feel like you're kind of stuck or stunted, it would be important to maybe do a reassessment or a reevaluation of everything that's going on for them. Another question that I noticed that came up that we wanted to address was trying to think of, about measurable goals. So it's interesting because over the past year we've run into a scenario where we're working with a lot of different states and a lot of different funding sources, and there are different requirements. And one of the new states we're working with has a pretty they have a lot of requirements for measurable goals and objectives, no matter what you're working off of, whether it's the IEP or the individualized service plan. And so what we've done a lot of tweaking around is, how do you measure not only typical goal progress, but the therapy services and the progress that's being made in the therapy sessions? And so a couple ways that we've tweaked it is, clearly the subscale is a great example of a visual you can use, but it's also a really helpful way to track where they're at with their mood, their feelings, and their behaviors. And so if you can either work with them to track it independently, or you can work with staff to track it, but that's a great way to look at fluctuations in behaviors, fluctuations in moods, fluctuations in feelings, and then also look at maybe like what was going on around that time when we saw these major changes in behaviors. A mood tracking type of system might also be really beneficial for therapists to use with an individual. And then in terms of like when you're tracking or looking for specific data around different therapy types of interventions, you could also be looking at like how many sessions did they attend and what their general participation levels were at, what their mood was at when they were in therapy sessions, and being able to kind of put some more specifics into place has been really helpful.
There's also been a few questions regarding if kids are not receptive to the cognitive behavioral therapy techniques that we've talked about. And so I think that these principles of reinforcement would be a great tool to utilize to get a child to buy into the techniques, the therapy. We have utilized a lot of sticker charts or reinforcement plans, star charts, whatever your child or your student or your client finds motivating. It's a process to find out what is motivating to them. And once you find that, then getting them to buy into those things by reinforcing when they're utilizing them or even when they try them. And it's about baby steps. It's about considering to think about it would be something you would reward. And then if you go back to the stages of change. So if they're contemplating it and then they're getting closer to doing it or they've agreed to do it, you have to really reward the very small steps because it takes a lot for all of us, not just a child on the spectrum, but for all of us to think about change, to think about doing things in a different way. And it's just really important to celebrate the very small successes.
And I think Alissa brings up a good point, which is it's very difficult for these youth to have motivation, and so we have to create the motivation for them, and so we have to build in the reinforcement in order to create the motivation.
Absolutely.
Okay. There were a few questions about blood work related to hormone levels and puberty, and unfortunately, I wouldn't say that we're have an expertise in that area. But again, we could potentially do some follow-up after this and do some consultation with some of the psychiatrists that we work with that might have more of an answer to those types of questions.
And in terms of, we talked a lot about puberty maybe being a marker at which a mental health diagnosis might change or the autism, quote unquote, might change. And it's not necessarily something that you can, you're not going to stop puberty. So even if you're looking at hormone levels and it's a better way to understand what's going on with the child and address the changing body or things like that. Okay. I think that might be it.
Thank you so much to Jennifer and Alissa for that presentation, and thank you all for joining us today. As Jennifer mentioned, we will be posting the presentation and an archived recording of the webinar on our website next week, and we'll be sure to send you an email with links to both as soon as they're available. We hope that you'll also consider joining us for another webinar on Thursday, February 19th, at 10 o'clock Eastern Standard Time, entitled Anxiety and Autism. And information and registration for that event are available at monarchcenterforautism.org. Thank you again so much for joining us today. Bye-bye.